Okay, so without further ado, welcome one and all to our hydroxyurea and other modifying therapies for sickle cell disease webinar. Really happy to have you folks joining us. As you can see, I'm joined by two lovely guests currently, but I'll be introducing them shortly. For those of you who don't know me, my name is Delaney Hines. My pronouns are he, him, and I serve as the member of the board of directors at SCAGO, as well as the education chair. So if you or any members of your network would like to refer to the information shared in this session, just so you know, as you've entered, the session is being recorded, and we'll post a recording of this session on our website for viewing at your earliest convenience. So, we do these learning sessions quite frequently, and one of our missions at SCAGO is to serve as not only a conduit for our members of our community, but also to ensure folks can access evidence-based, up-to-date information like we have prepared for you this morning. So today's session is important, as you can imagine, as all of them are, because hydroxyurea presents a lot of promise as a potential therapy for sickle cell disease, and it's positively impact many lives of members of our community. So we're joined by a number of experts who bring a number of different perspectives, and we hope to guide you through an informative session today that will help give you a bit more insight about what it means to potentially pursue this as a therapy or therapeutic benefit for you. So in today's session, you'll hear from three guests. You see two on my screen right now. Our third is currently preoccupied with child caregiving needs, which we know is of the utmost importance and is tantamount to anything. So Dr. Kuo is the one person who we currently can't see on the screen, but he's been gracious enough to provide us with a pre-recorded version of his session. So I'll play that first, and then I'll introduce our other two speakers. So just want to kick things off with our agenda, which will start with a land acknowledgement and some housekeeping rules. Then we'll be followed by the presentations from our guest speakers, and then we have a dedicated question and answer session that follows that. So we do ask that you save your questions, thoughts, or concerns until the latter portion of our session. This is a time when our guests will be able to answer your questions individually. Also, you'll automatically know that when you've joined, your microphones have been disabled, and they will stay that way for the duration of the webinar. But if you'd like to ask a question, please do so using the Q&A chat or the Q&A function that is currently listed in the toolbar. Also, we'll try our best to answer all questions during today's sessions, but in the event that we can't arrive at it, please do email them, and I can share my email at the end of the session for you to forward them, and I can make sure those questions get answered promptly. Closed captioning is also provided for those who require that accessibility, and please do use respectful language in the chat, so no profanity or inappropriate images were posted, please and thank you. And please do not post any other materials unrelated to today's discussion topic. We really want to try and keep discussions and comments on topic as much as possible. So, SCAGO does reserve the right, just so you know, to pause or remove the session or seek removal of a participant who doesn't abide by these rules. So we thank you in advance for understanding and agreeing to this positive learning atmosphere and experience. One last disclaimer. I know I'm doing a lot of talking, but it's important. Remember that the information that's shared today does not constitute medical advice, and it's shared with you for information purposes only. So no materials shared with you today are intended to be a suitable substitute for professional medical advice, diagnosis, or treatment. Please always seek the advice of your physician or any other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking any new healthcare regimen. So please do not disregard professional medical advice or delay seeking it because of something that was said during today's webinar. Okay, moving right along to our land acknowledgement. I'd like to acknowledge the land that we're currently have the opportunity to gather on today. I'm joining you folks from Ajax, Ontario, which is what is colloquially known as, but it's a traditional territory of the Haudenosaunee, Huron-Wendat, and Anishinaabe, Mississauga, adjacent to the Mississaugas of Scugog Island First Nation. It's currently covered by the Williams Treaty. I personally arrived here as a child of settlers who arrived here through an immigration pathway. Both my parents are of Jamaican ethnicity, and they arrived here in the late 70s, and I've been the fortunate, little one to be able to grow under their parentage and their stewardship. Many Black communities and Black members have come to this country, have come through various mechanisms, including the transatlantic slave trade. So it doesn't fall, flat on me that a number of folks, the distance traveled has been long and arduous. But I'm happy to be here and I recognize the hardships that many Indigenous communities have also faced in their journey living in this country. But I think that we can all appreciate the benefit and the privilege we have to be able to occupy and move freely on this land. So, oopsies, sorry about that. Now to the main event. Without further ado, good morning, Dr. Ivy. Good morning, Ms. Oduwole. Thank you so much for taking the time out of your Saturday to be with us this morning. I'm also going to introduce Dr. Kuo, whose presentation I'll be pulling up shortly. So Dr. Kuo, who will be joining us around 12:20 for the Q&A session, he's an adult hematologist and clinician investigator in the red blood cell program at Toronto General Hospital or the University Health Network. He's also an associate professor at the Division of Hematology and an assistant professor at the Institute of Health Policy Management and Evaluation at U of T. His clinical focus is on rare congenital hemolytic anemias, and his research focuses on genetic modifiers and novel therapies in rare congenital hemolytic anemias, the impact of white matter changes on neurocognitive outcomes in sickle cell disease, and non-chelating strategies in the treatment of iron overload. His session will give folks an overview of transfusion medicine, its risks and benefits supported by clinical evidence. And Dr. Kuo is currently working double time, as I mentioned, attending to childcare duties this morning, so he'll be joining us a bit later. Next, we have Dr. Donnell Ivy, who you see on the screen, at least to the top of my screen. Dr. Ivy personifies hope, persistence, and possibilities. Born and raised in North Carolina, he has never given up on any dream that is deeply personal and meaningful. Childhood poverty didn't stop him, and sickle cell disease, as we all know, a serious chronic health condition, hasn't stopped him either. Dr. Ivy was the first in his family to go to university. After receiving an undergraduate degree, he earned a medical degree at East Carolina University on a full scholarship. Kudos to you. His studies continued at the University of North Carolina, Chapel Hill, where he received a master's degree in public health. Before coming to Canada, he worked as a medical officer with the National Institute for Health and with the HRSA, the Health Resources and Services Administration in Washington, D.C. He is currently Vice Chief Medical Officer for the Sickle Cell Disease Association of America. And as a medical officer, he helped innovate systems of care across the United States so individuals living with sickle cell, whether in big cities or rural areas, can access medical professionals and comprehensive care. Thanks, Ali. Scholarship opportunities help support Dr. Ivy's curiosity, hard work, and determination, creating wonderful opportunities and advancing his dreams. As the clinic's director of community outreach and education, he shares his enthusiasm and inspiring stories, speaking with schools and community groups about creating possibilities, even when obstacles seem insurmountable. Dr. Ivy also provides leadership around the Possibilities Clinic Assessment Award, given each year to student recipients in need to support learning and achievement. His contributions to the clinic resonate with his core values. In his own words, giving back is just as important as never giving up. So Dr. Ivy will provide an overview of the hydroxyurea experience from both the perspective of someone working in public health and trying to steward advances in, interventions that can be readily accessible, as well as a person with lived experience. And last but certainly not least, we're joined by Mary, who took it upon herself to co-locate in the library to make sure she has no interruptions. She's an academic foundation in biochemistry and environmental chemistry. She's also a proud member of our advocacy team. This past March, Mary was on Queen's Park advocating for changes in the Newborn Screening Ontario program alongside SCAGO, and she leverages her expertise within the realm of consulting. Her focus lies in optimizing laboratory methodologies and refining information systems. She's a devoted mom to two remarkable children. She holds a personal stake in sickle cell disease due to a family member's battle with the condition. Her fervent interest lies in advancing the SCAGO mission, which she proudly does so, and she does it very well, and aiming to broaden awareness of sickle cell disease across Ontario and beyond. So during her session today, she'll be discussing, providing a walkthrough her journey as a parent of a parent and the considerations that went into determining whether or not hydroxyurea was the best therapy for them to pursue. And of course, her hobbies also include volunteerism and volleyball, and she's a passionate advocate for social justice and loves to travel. Okay, We're now into the meat of today's presentation. Welcome, welcome, welcome. Folks are waving to you. I hope you can wave back. I'm now going to switch gears, and we're going to take some time to hear from Dr. Kevin Kuo, who took it upon himself to ensure he wouldn't leave you folks wanting for more, and has sent us a pre-recorded presentation. So just give me 1 second to pull that up.
Good morning. My name is Kevin Kuo. I'm an associate professor in the Division of Hematology at the University of Toronto. And in this SCAGO Learning for Life session on hydroxyurea and other modifying therapies for sickle cell disease, I'll be talking with you about transfusion. These are my conflict of interest disclosures. When we think about transfusions, we have to think about the potential benefits of transfusions as well as the potential risks. And only by balancing the benefits and the risks will we be able to use transfusions judiciously. And to me, this is a shared decision between the patients and the clinicians. Let's start with the risks of transfusions. When we think about risks, we think about whether certain bad things can happen or not. For example, if the risk is 1 in 13, such as the risk of sensitization, we're talking about a relatively common thing that can happen. On the other hand, the risk of catching hepatitis from transfusions, 1 in 27 million, is extremely low risk. However, when most people think about transfusions, they often think about the infectious risk. But in fact, majority of the infectious risk is extremely low. You can see here, for example, the risk of West Nile virus is less than 1 in a million. Risk of hepatitis B is less than 1 in 2 million. Risk of HIV is 1 in 12.9 million. Risk of hepatitis C is 1 in 27 million. Well, how does that stack up to, say, the risk of winning the lottery, Lotto 649? In fact, it's pretty comparable. It's 1 in 13 million to win this Lotto 649. So infectious risks is what I called pink unicorn. And they're extremely rare events. On the other hand, the non-infectious risks are the more common thing that we worried about with transfusions. And what are they? They include the risk of getting a hemolytic transfusion reaction, the risk of having a fever from transfusion, and the risk of fluid overload, as well as the risk of acute lung injury, as well as other things like minor allergic reactions, as well as the delayed hemolytic transfusion reactions. And in terms of how common they are, in fact, they're even more common than, say, the lifetime risk of being struck by lightning in the US, which is 1 in 15,000. Well, why are people with sickle cell disease at higher risk of getting transfusion reactions, especially hemolytic transfusion reactions? And this is because of a thing called red cell antigen. So on the red cells, there are these proteins that maintain the functions of the red cells, but they are also, if you can think about it, markers. Now, everybody's markers are slightly different, of different compositions or different combinations. And when we transfuse people, we would, of course, try to match their blood as best as possible. Often people think about matching as being just matching the A, B, and O, but with people with sickle cell, we go even beyond that. And that's because, as you can see here, if we do extend antigen matching, for example, we looked at those in group A here, compared to those who did not go through extended antigen matching for cross-match for blood, you can see the number of antibodies is actually quite high if we do not do this extended matching. Now, why is it that there is this increased risk? And it's because there's differences in terms of these antigen makeup in people of African ancestry compared to those of other non-African ancestries. And this is because all humans originated from Africa. And because of that, those who are from Africa, the ancestors have a sort of longer time for the genes to recombine, and as well as the ability to have a greater genetic diversity. Now, this genetic diversity then gets translated into these variants that we see. For example, in 90%, more than 90% of Caucasians, we see the RHD gene, but in those of African ancestries, we see 66% having this premature stop, or 19% having a gene deletion. In patients with African ancestries, 15% can have this RHD-CED hybrid. And often when they're typed, because again of the limitations with the way we can look at these antigens, so-called serologically, it's a way for us to find matches. They can often be mistyped as a D negative and a C positive. There's also other variants like the CES, for example, that are found in 22% of Africans that are not found in Caucasians. Despite our best efforts at doing extended phenotypic matching, antigen matching for people with sickle cell disease, there is still the risk of delayed hemolytic transfusion reaction. And the way delayed hemolytic transfusion reaction works is that a person initially creates an antibody against a red cell antigen during pregnancy or during a transfusion. Now, this antibody, the first time when it's created, usually doesn't do anything. The antibody then lays dormant until the person is re-exposed to the same kind of red cell antigen again. This usually happens in 1 in 2,500 units of red cells transfused. And this is equivalent of being on automated red cell exchange transfusions for 35 years, or being on partial manual exchange transfusion for 104 years, or maybe even if someone can live for that long. Hemolysis with DHTR usually occurs within 24 hours to up to 28 days after transfusion. Most of them are benign, but can be life-threatening if the person has very severe anemia as a result of the breakdown or the hemolysis of the blood, or if there's kidney failure. Now, the most dreaded complication of hemolytic transfusion reaction is what we call hyperhemolysis. This is extremely rare, but potentially life-threatening. We actually don't know what the incidence is, but we usually see a few cases at Toronto General Hospital per year. But it's still quite low compared to the amount of transfusions that we give. Often present with in those with fever and painful vaso-occlusion episodes, and is usually not found in people who are stably chronically transfused. The hallmark of hyperhemolysis is the hemoglobin after transfusion is much lower than the hemoglobin before transfusion. Also, is associated with a very low reticulocyte count. And just as a reminder, reticulocyte is these young red cells. There's, of course, also evidence of hemolysis or the breakdown of red cells. Now, additional transfusions will worsen the hemolysis and definitely can occur even if we do this extensive antigen matching. What are the proposed mechanisms? We think it could be bystander hemolysis, where there is interaction between an unknown antibody and a transfused foreign antigen, which then will activate the complement system, which is part of our innate immunity system. There's also suppression of the body's ability to make red cells, as well as activated macrophages, which will start eating up both the transfused red cells as well as the sickle red cells inside the person's body. How do we manage hyperhemolysis? It really depends on the severity of the anemia and the rate of hemolysis. We definitely need to avoid further transfusions. We will start with immunoglobulin and methylprednisolone, which is a strong type of steroids. If those don't work, then we will resort to antibodies like tocilizumab, rituximab, or eculizumab. Now, with these sort of antibodies, we need to make sure that the people are vaccinated and are on preemptive antibiotics to prevent infections. Of course, we need to monitor the hemoglobin very carefully, as well as the reticulocyte count, the hemolytic markers, as well as hemoglobin electrophoresis. Last but not least is that people who are on transfusions, especially those who are on chronic transfusions, are prone to having transfusional iron overload, even though that this is less likely in people with sickle cell compared to those with transfusion-dependent thalassemia. It doesn't mean that it can't happen. It's just that it can be just as severe. First of all, iron gets loaded in the liver. As you can see, dark means a lot of iron. And then it can load in the heart as well, you can see here. And also in different hormonal producing tissues that could cause low testosterone, low estrogen, low thyroid, as well as diabetes. We treat, of course, with iron chelation, but as you can see, the iron comes out very, very slowly. You can see the brightening of the liver as the iron comes out, but you can see how in the heart, the iron stays, and it's really hard for it to budge. Now, what about sickle cell complications where transfusion is indicated? We've talked about the risks. Now we're going to talk about the indications for transfusions. Treatment for acute stroke is, we definitely would transfuse in those cases. We recommend red cell exchange, preferred over top-up, and the evidence comes from 7 observational studies listed here. And for those who have already had a stroke, like in the previous scenario, we would like to prevent a second stroke. And the way to prevent second stroke is also chronic transfusion to maintain a sickle hemoglobin of less than 30%. And the evidence is actually very high quality due to the fact that there is a randomized controlled trial to support this. And this is so-called switch study. In patients with sickle cell disease who are less than 18 years old, who already had a stroke, and they're on transfusions to prevent a second stroke, patients were randomized to either continuing on transfusions or to hydroxyurea at maximum tolerated dose as an alternative to transfusions, and they were looking at second stroke. Unfortunately, the study had to be stopped early because those who were switched to hydroxyurea, of the 67, 7 of them had a new stroke. There was no stroke in those who continued on transfusions. So transfusion is still the standard of care for patients who had a first stroke and is there to prevent the second stroke. In terms of preventing the first stroke, as we all know, there are lots of patients who are at risk of stroke. And the way to prevent it, recommendation is to start transfusions if the transcranial Doppler velocity is greater than 200 centimeters per second, and to maintain a sickle hemoglobin of less than 30%. Very high quality of evidence. In fact, there's 3 randomized controlled trials to support this. Before we go into that, though, let me describe what transcranial Doppler velocity means. You can imagine that our blood vessels in the brain is like a garden hose, right? If you clamp down on the garden hose, then the water will flow very fast. Similarly, if there's stenosis or narrowing of those blood vessels in the brain because of damage by the sickle cell, then the blood is going to flow very fast. And we can use a Doppler to measure how fast the blood is flowing. If the blood flows faster than 200 centimeters per second, it's considered to be abnormal, and there's a 40% risk of stroke in 3 years. And this needs to be done yearly for children when they can first lay still, usually around 2 years old, until when the bone window closes, so around early to late teens. So we don't do this in adults because of the closure of the bone window. So the first study to support this is the STOP study, where patients with sickle cell disease, ages 2 to 16, with an elevated transcranial Doppler velocity were randomized to either no transfusions, which is the standard of care at that time, to transfusions. and they were looking for signs looking for evidence of stroke by MRI. And you can see here that the study overwhelmingly favors those who are on transfusions. Because of the 63 patients on transfusion, only one patient had a stroke. Of those 56 patients not on transfusions, 11 had a stroke. This translates into relative risk reduction of 90%, which translates in a number needed to treat of 6.7. What number needed to treat means is the number of patients you need to be put on transfusions in order to prevent a stroke. And in this case, you need to treat 6 patients in order to prevent 1 stroke. This is much better than any other therapy that we have known in medicine. So it's highly effective. Then the same group of patients, of course, they're benefiting, but then the parents have to take their kids to get transfused every 4 weeks. Of course, then raises the question is it possible to stop the transfusions after you've been on transfusions for a little while? And so again, the same group of patients who have been on transfusions for a little while were randomized either to halt the transfusions or to continue on the transfusions. And again, you can see overwhelmingly, the study is in favor of continuing on transfusions. There was no events in those continuing transfusions, and there were 16 out of 41 patients who had an event when the transfusions stopped. In fact, most of the events happened within the first 12 months. So this validates our approach that patients, continue on transfusions. Now, that was compared to no transfusions, but what about comparing to hydroxyurea as an alternative? Again, same group of patients. Is it possible that, we can use hydroxyurea instead of transfusions? So a randomized control trial was set up to look at this, called the Twitch study. Of the 121 patients that were randomized, it was shown that hydroxyurea was not inferior to transfusions. And this now established hydroxyurea as a possible alternative to transfusions for those who have been on transfusions for a while, to prevent the first stroke in those who are at high risk of stroke. Next, I'm going to talk about is high-risk surgeries. And high-risk surgeries, such as cardiovascular surgery or neurosurgery, we recommend exchange transfusions to keep a sickle hemoglobin less than 30%. There's no randomized control trial on this, and the reason is because we feel that these patients are simply at too high of a risk to develop complications, and everybody should get exchanged. But what about those who will be undergoing low to medium risk surgeries? Our recommendation is that, the international recommendation is that if the hemoglobin is less than 90, you top up with the transfusions to hemoglobin of 90. If the hemoglobin is greater than 90, then you would engage in exchange transfusions to keep the sickle hemoglobin to less than 50%. This data is extrapolated from a study called TAPS, which it's a randomized control trial where patients with sickle cell disease, ages at least 1 year, engaging in low to medium risk surgeries, were randomized to either no transfusions or to the transfusion schema that I just talked about. And you can see here that of the 34 patients who were randomized to transfusions, there were 6 events in terms of postoperative complications. But of the 33 that were not on transfusions, there were 16 postoperative complications, thus favoring transfusions. If we dissect this more, of the 6 events in the transfusion group, 3 of them were sickle cell related complications. Of the 16 in the no transfusion group, 12 of them were sickle cell complications. Furthermore, of the 12 that had sickle cell complications, majority were chest crises, 9 of the 12, and then the other 3 were pain crises. So you can see here that chest crises is very deadly, something we want to prevent, and by transfusing before the surgery, we can prevent chest crises and other sickle and non-sickle related complications. Next, I'm going to talk about acute chest syndrome or chest crises. The recommendation is to start with a top-up transfusion. If the patient is not responding to the top-up transfusions, or if the patient's hemoglobin is greater than 100, then you would go on exchange transfusions. And what's the rationale for this? Well, in fact, there is one randomized control trial, one prospective cohort study, and one retrospective analysis of a randomized control trial. And you can see at the bottom here that if we combine these data together, it favors transfusion. Now, next is pregnant patients with sickle cell disease. We know that patients who are pregnant, sickle cell patients who are pregnant have high risk of having clots, high risk of infections, high risk to the babies, as well as high risk to themselves during the pregnancy. Yet 30% of the pregnancies in people with sickle cell disease remain uncomplicated. So when we recommend transfusions, we only recommend it in certain settings. This includes things like acute chest syndrome, recurrent painful vaso-occlusion episodes, intrauterine growth retardation, twin pregnancies, or having a symptomatic anemia or hemoglobin less than 60. And of course, the next question, of course, is, does a prophylactic transfusion help to reduce pregnancy complications? We don't have really good data on this, but what we do have is what we call meta-analysis, which is a way to group all the studies together, especially small sample size study together, and to see whether a proposed treatment could be beneficial. It's not as good as a randomized control trial, but is a good substitute for it. In this case, it's been shown to reduce mortality of the mother as well as the baby, and to reduce recurrent painful vaso-occlusion episodes and pulmonary complications, which includes chest crises and pulmonary embolism. But it the evidence for preventing preeclampsia, which is actually quite dangerous for both the mother and the child, for small for gestational age, low birth weight, as well as preterm birth, is equivocal at this time. Because of what we mentioned previously, transfusion doesn't work to prevent all potential complications for sickle cell disease during pregnancy. We, as in Dr. Kinga Malinowski from Mount Sinai Hospital, Dr. Nidhi Shahada from Mount Sinai Hospital, and I have developed a model to predict sickle cell disease pregnancy complications. And we're currently in the process of validating it in other centers in the United States and in France. Now, there's a number of indications where there's no clinical equipoise or uncertainty. And these includes things like priapism, avascular necrosis, multi-organ failure, symptomatic anemia, et cetera. Now, even though there's no evidence, does that mean we shouldn't use transfusions, right? On the other hand, should we use transfusions for all of them? I think, these are the questions that really should be weighed based on the risk and benefits, and should be a joint discussion and joint decision between the patient and the clinicians. And I would say that just because we don't have evidence doesn't mean we should do it. We shouldn't do it. For example, parachute use to prevent death. I mean, there's never been any randomized control trial on this, right? And yet, we trust that parachutes will, save us from death if we were to wear it to drop out of an airplane. On the other hand, transfusion is definitely not the cure for all evils in people with sickle cell disease. Should we treat it as a treatment of last resort? Well, again, risk and benefits really needs to be weighed, and I think it's a real nuanced decision that we have to have when we speak to our healthcare practitioners. And with this, I draw to a close, and I welcome any questions. Thank you.
Beautiful. Apologies, folks, if there was a bit of a lag there. I've been navigating some internet issues on my end, but we can definitely share that recording following the session. As I mentioned, Dr. Quo will be joining us towards 12:20. So if you have any questions, you can enter them in the chat now. I reserve them for when he signs on. But next up, without further ado, we have Dr. Donald Ivy, who will be providing his perspective from both a public health practitioner as well as a member of the Sickle Cell Disease Association of America. Over to you, Dr. Ivy.
Thank you so much, Delaney. I hope everyone can see me well. Thank you so much for inviting me to give this presentation to SCAGO. I know you mentioned that the internet just went out. If it goes out on my end, I do apologize ahead of time. I have been having internet, difficulties lately, but hopefully I can get through this without it going out. So I do have a couple of slides I may share towards the end of my presentation, my time. But I didn't do slides intentionally today because I wanted to talk to you about my personal experience and my personal experience with hydroxyurea for the treatment of sickle cell disease. I was born in North Carolina, as Delaney mentioned, back in 1971. So I am currently 52 years old. I'll be 53 in September. I was born with sickle cell disease hemoglobin SS. And, all sickle cell patients, I highly recommend that you get to know your sickle cell type. You should know if you have hemoglobin SS, if you have hemoglobin SC, if you have hemoglobin S beta thal 0, beta thal plus. Those are items that you should know as a sickle cell patient. You will often hear that hemoglobin SS and hemoglobin S beta thal 0 are the most severe types of sickle cell disease. However, all types of sickle cell disease can be severe, and I've met individuals with hemoglobin SC disease, with hemoglobin S beta plus, who have had severe and significant complications. Now, I was born back in the 70s. My mother married my stepfather, who was in the Air Force. And I traveled around quite frequently with my stepfather. He was in the military in the Air Force, so we traveled around quite frequently. And during my earlier years, I would have frequent crises. I would often get sad about the crises, not because of the pain. The pain was definitely a huge part of it, but also because it meant time away from my family, my brothers, and so forth. So whenever I was gonna go get whenever I got an IV put in, I would cry, not because of the IV, but because it represented that I had to stay in the hospital. But at any rate, I would have frequent crises when I was younger, particularly at certain times of the year. If I got in swimming pools, for example, or during the winter was when it was usually the worst. I had a slightly different experience. So my mother, she became ill with a certain condition, and my mother and stepfather separated. And I went to live with my grandmother in North Carolina. Now, her view on certain things was a little different, and she kind of managed my sickle cell a little different. She did it in a way I would not recommend, but it did help me in the long run. And that was even when I was having severe crises or when I was having pain, she still forced me to do chores. So I would still have to get in. We had a wood burning stove, so I would still have to get in the coal and wood. When I was in crises, I would still have to wash the dishes, make the bed, do other things. And that kind of taught me that even when I'm feeling not so great, even when I'm feeling ill, that I have to still get things done. Now, as I said, I don't recommend that because sickle cell disease is a very significant and severe disease, and it must be treated right away. It must be addressed, the complications of sickle cell disease right away, because certain aspects of sickle cell disease can be very dangerous and deadly. Individuals with sickle cell disease have died from overwhelming sepsis or an infection in the blood. They have died from splenic sequestration or significant strokes. I was fortunate that while I was living with my grandmother, I didn't have any of those significant complications. But you should always get the your sickle cell disease properly managed and properly treated. But I would just say from that experience that it's also important for individuals with sickle cell disease that to not use sickle cell disease as an excuse, to try to say, hey, when I am feeling up to being able to do certain things, even when I'm feeling a little bit of pain, I'm going to try to push through. I'm going to try to live my life. I'm going to try to be the best me I can be. You want your sickle cell disease managed. You want to be able to go to your doctor and talk about managing your sickle cell disease. You want to be able to treat that pain. But I do encourage you to live a life worth living when you do feel up to it, and not using sickle cell disease as a crutch. But with that saying, so my grandmother pushing me allowed me to really, learn how to push myself with sickle cell disease. And as Delaney said, I was able to push myself with school, with education, and I was the first person in my family to go to university. Now, university was a challenge with sickle cell disease, and I would have significant crises. And it would be very tough when you're taking certain courses to manage your sickle cell disease and do well in school. It's hard to pass biochemistry or physics when you have to spend like weeks or even a month out due to sickle cell disease. So my first couple of years at university, I was able to do well. I never got to a point that I was in danger of failing out of university, but I could have definitely done better. But I did have frequent crises with sickle cell disease while I was at university. In those first 4 years of university, the first 3 years of university, but I tried to persevere on, and I said, okay, I'm not going to let sickle cell defeat me. So whenever I felt up to it, I made sure I did well with my classes, study hard to continue on at university. But sickle cell disease is a challenge, and I would have significant crises in university that would be a barrier. It was in my third year of university that I had a very severe crisis that started in my hips. And I went to the hospital because I had significant pain in my hips. And during that hospitalization, something happened where I had an episode of acute chest syndrome. And acute chest syndrome is a very significant illness in sickle cell disease. It's one of the leading causes of death for adults with sickle cell disease. It's where you start having a sickle cell crisis in your lungs. Your lungs become damaged and can no longer transfer oxygen to the red blood cells like they should. And so because of that, you become, your oxygen saturation starts dropping very low, and it can be very dangerous to you. The treatment for it, just as Dr. Ko was discussing a few minutes ago, is usually like an exchange transfusion or transfusion therapy. I was in Raleigh, North Carolina, so I went to North Carolina State University for my undergraduate education. And I was in Raleigh, North Carolina, and the doctor there identified quickly that, hey, this is a condition that they're not used to treating. So they did reach out for help. They reached out to the University of North Carolina at Chapel Hill, and I was transferred from the hospital in Raleigh, North Carolina, to the University of North Carolina, Chapel Hill, where they had specialists that were more knowledgeable of treating sickle cell disease. I was on a respirator, intubated for about 2 weeks during that visit in ICU the whole time. And it was so bad that at one point they called my mother and they said that she needs to come visit me because they didn't know if I would live, past this episode. So sickle cell can be very, very dangerous. It was during that hospitalization, though, and during my interaction with that specialist at the University of North Carolina, Chapel Hill, where he informed me about hydroxyurea. I had heard about hydroxyurea a little bit. I knew that, hey, this is a new therapy for sickle cell disease that they were testing out. I heard while I was at NC State about it, and they had talked about it in one of my biochemistry classes. Hey, this is a
We seem to have lost Dr. Ivy. Yeah, the internet's been plaguing us all this week. Maybe we can give him a few minutes to sign. Awesome. There you are. You're back. Perfect. Okay.
I don't know where I left off.
You
I
just left off
apologize.
at the point when no apology necessary about being introduced to hydroxyurea at North Carolina Raleigh Hill, and then after being intubated for 2 weeks.
Yes.
Perfect.
So as I said, I was transferred to UNC Chapel Hill for treatment, and at that time I met a hematologist that had been working on hydroxyurea, and he asked me about hydroxyurea, would I like to start it? I had heard some about hydroxyurea in some of my classes, but I was like many African Americans, a little skeptical when you hear about new therapies, when you hear about new research going on, you get kind of skeptical and you think back to the Tuskegee experiment. Tuskegee experiment was an experiment that was done in African Americans in Tuskegee, Alabama, without their knowledge or their consent. And so a lot of African Americans, people of African descent, and even other groups, they may be skeptical of research or they may be skeptical of new drugs because they think back to the mistreatment that has happened in the past. So I was one of those that was a little skeptical, but this doctor really took his time, talked to me about hydroxyurea, and really encouraged me to say, hey, you should really consider starting hydroxyurea. And I will remember one thing that stuck with me at the time. So I had just had an episode of acute chest syndrome that required me to be transferred from one hospital in Raleigh to the hospital in UNC Chapel Hill. And he said to me, because I was a little skeptical, he said, well, Donnell, the reality of it is that it's an experimental drug. They didn't know at the time. You could take hydroxyurea and it could cause, 10, 15, 20 years from now, it could cause cancer and you could die from the cancer from hydroxyurea. But he said, but you just had a very severe disease complication with sickle cell disease. And sickle cell disease is a very severe disease. So the chances of you having another episode of acute chest syndrome are very high. You could have another acute chest syndrome episode in 2 weeks, a month, a year from now, and then that can kill you. So when we start thinking, so that made me really start thinking about, well, hydroxyurea, yeah, it's experimental. It could be dangerous. It could cause cancer. It could do whatever. But sickle cell is a severe disease as well. And I just had a very significant episode. It can lead to my death early as well. So I started hydroxyurea, and that was back in 1996. So I've been on hydroxyurea for over 28 years now. And it was a game changer for me. Hydroxyurea really changed my life. So I went from having 3 to 4 crises a year that would require hospitalization. That doesn't even include the crises that I would take care of at home without going to the doctor or the emergency room. Those 3 to 4 crises a year would usually require hospitalizations that could last a week or months at a time. So I went from having those 3 to 4 crises a year that required hospitalization, countless other crises that I dealt with on my own, to on hydroxyurea having no crises at all. I mean, literally, it's like the crises just stopped. And because of that, I was able to do much better in school. I was able to start working out and exercising. I was able to put on weight, and it totally changed my life. I was able to focus on school such that I went from where, okay, yeah, I was getting by, I was doing okay, to I was making the dean's list every semester. Dean's list, dean's list, dean's list. And so for me, and I have to say I'm blessed, because I will mention later that I know that it doesn't work as well for everyone, but it did work for me and it changed my life. You know, and it allowed me to go on to continue my education, complete my degree at North Carolina State University. I had a double major in zoology and microbiology. I was able to complete that. And then the doctor that I had met at UNC Chapel Hill, I started working with him on a study about hydroxyurea. Now, hydroxyurea, what it does is your body, when you're inside of your mother before you're born, you make a certain type of hemoglobin called fetal hemoglobin. Once you're born, you take your deep breath, your body changes, and it decreases the amount of fetal hemoglobin it makes and start making adult hemoglobin. In sickle cell disease, the problem is in that adult hemoglobin. So red blood cells are what's called a tetramer. That means 4 like protein subunits that work together. 2 of those protein subunits are an alpha chain, and then 2 of them are a beta chain. And it's in that beta chain where you have the defect for sickle cell disease. Because there's a defect in the protein of the beta chain, when it's not holding on to oxygen, it takes on a shape that causes the other proteins to start sticking to it. So in a deoxy state, your beta subunits start sticking together. And then, if you think of your red blood cell as a large bag with a lot of tiny little 2x4s in them, and then if those 2x4s started sticking together from end to end, they will eventually be so large that they would cause that cell to have to take on a different shape in order to hold those chains together. So that's what causes sickle cell disease, is those hemoglobin molecules starting to stick together and causing that red blood cell to become distorted in sickle shape. And as I said, that's in that beta hemoglobin unit. Now, the fetal hemoglobin doesn't have that issue. So what hydroxyurea does,
He's dropped out again, I see. Humble apologies, folks. The internet seems to be giving us issues. Can you hear me at least? Fantastic. Thank you, Maria.
sorry about that again.
No worries. I'm glad you've been jumping back on quickly. So back to your point about the tetramer,
Yeah.
hydroxyurea, and what it does. Perfect.
And so I don't know where I dropped off, but the problem is in that beta hemoglobin subunit. Hydroxyurea causes your body to produce that fetal hemoglobin subunit, and that fetal hemoglobin subunit doesn't sickle. Now, when it does that, I will have to be honest, hydroxyurea interacts with the DNA, right? But there has as I said, I've been on hydroxyurea for over 28 years and counting. I'm not stopping hydroxyurea anytime soon. And as I mentioned, it allowed me to go on to do much better in undergrad. I was able to get my degrees from North Carolina State University. I was able to then go to medical school at East Carolina University. I actually got accepted to several medical schools, including UNC Chapel Hill, but I got a full scholarship to East Carolina, so I decided to go there. And it allowed me to do well in medical school. Now, hydroxyurea for me had been that game changer. But what happened was that once I got into my residency, I saw that not a lot of sickle cell patients knew about hydroxyurea, or you would talk to them about it and they'll say, well, I'm not going to take it because it might cause cancer or it does other things. And then some of them say, well, it doesn't work for me, without really fully trying it. And what I observed in my residency is that, we could have all the cures in the world, but if no one is willing to take it because they don't have the knowledge about it, or because they're not aware of it, or because they're fearful of other things about it that may or may not be true, then what good is having those therapies? What good is having the cure to sickle cell disease if no one is gonna take it, or if it's not getting to the people that need it? So what I observed is that although I had benefited quite a bit from hydroxyurea, the sickle cell population as a whole wasn't getting the knowledge about hydroxyurea, wasn't benefiting from hydroxyurea. We have this wonderful therapy, but there's misconceptions, there's misunderstandings about it. And so I decided during my residency that I wanted to go back and try to address problems in the healthcare system that prevent individuals with sickle cell disease from really getting that optimal treatment that they should have. So I decided to go back and get my master's in public health so I can work on, hey, well, what are those systems issues, those public health issues, those public health structures that can help to improve sickle cell care? So I went back and got my master's in public health from UNC Chapel Hill. And then after that, I was fortunate enough to start working at the National Heart, Lung, and Blood Institute on the National Heart, on the sickle cell disease guidelines. And I was fortunate in that during my time at NHLBI, I were able to meet other people that knew that, okay, hydroxyurea has been out, and by that time, it it came out in the 1990s, early 1990s. So it had been out for about 10 years. But they recognized that, hey, only a small percentage of individuals that can benefit from hydroxyurea were taking it. And they recognized that there were barriers to the use of hydroxyurea in our society. And they also said, hey, how do we start addressing these barriers to the treatment of sickle cell disease? And that's when we started working on the sickle cell disease guidelines of 2014 at NHLBI, at the National Heart, Lung, and Blood Institute. During that process, we looked at hydroxyurea utilization. We looked at other data around sickle cell disease, the treatment of sickle cell disease. And one of the barriers we ran into was what Dr. Coe was talking about earlier. The scientific evidence is not very, very strong in a lot of the treatments for sickle cell disease. Some of it is just based off of a few studies, or they're just based off of observances, or they're just based off of studies that have very few participants. So it's hard to make those general statements that, hey, doing this is the best strategy in sickle cell disease. We had a few areas in sickle cell disease that we had very strong evidence. We have very strong evidence around using penicillin prophylaxis in children and newborns with sickle cell disease. We have very strong evidence, as Dr. Coe was presenting, that doing blood transfusions for certain treatments, particularly around stroke, in sickle cell disease is very beneficial. And at the time, we had very strong evidence that hydroxyurea is a very effective therapy for the treatment of sickle cell disease. But a lot of other things in sickle cell disease doesn't have that very strong evidence. So one of the challenges that we had is writing guidelines that didn't have the strength of evidence that certain doctors would want to see when they start doing their treatment. Because you have to understand that when doctors practice, part of that practice is based on scientific evidence, and part of that practice is based off of, hey, well, we've observed that this works. There's no randomized controlled trial about it. This hasn't been tested against certain standards, but we've been doing it for so long and we think it works. So so in this number of cases, we'll continue to do it. But when we started drilling down and really looking at, hey, does this work? Does that work? In sickle cell disease, some things are harder to prove than others. It's hard to prove that, hey, using, certain pain medicines is more beneficial than using other pain medicines. But we had that evidence around hydroxyurea. And that's what I wanted to really talk about right now, is that figuring out how we make sure that the sickle cell population and the doctors that treat sickle cell patients are aware of that evidence around hydroxyurea. So we were able to do the guidelines, and as I mentioned, we had the proof with hydroxyurea, and that allowed us to then work on one strategy that we wanted to work on. Because what we observed was that there were barriers to hydroxyurea utilization. I'm just going to share a couple of slides here as I finish out my presentation, because I do want to get to the general discussion and be able to answer the question. But this is a slide that's created by the NHLBI, individuals that were there. And it shows that, you know, if you go back to the 1910s, the 1970s, the life expectancy for individuals with sickle cell disease was about 10 years or less. Individuals with sickle cell disease will have overwhelming infections, the sepsis I was speaking about earlier. They would have splenic sequestration. They would have significant and severe strokes, and they would die early from those infections, from the splenic sequestration and the strokes. There was a study that was done back in the 1970s that demonstrated that if you gave penicillin prophylaxis to babies, it would reduce the amount of deaths from infection. And because of that penicillin prophylaxis study, they were able to demonstrate that, hey, if we can identify babies with sickle cell disease and get them on penicillin prophylaxis, we can improve life expectancy and life outcomes. So because of that, newborn screening was started in the United States in the 1980s and 90s. I'm happy to say that currently all 50 states in the United States screen for newborns. Every newborn, whether black, white, Asian, you name it, they screen them for sickle cell disease because they recognize if I can identify babies with sickle cell disease early, I can get them on penicillin prophylaxis and they can do better. We had the penicillin prophylaxis when I was a child, so the 70s, 80s, 90s. The only treatments we had for sickle cell disease were penicillin prophylaxis, as I just mentioned, and I was on penicillin prophylaxis. We had IV fluids and we had pain medications. We also had the oxygen that they would put in the nose to help with this oxygenation. But that was it. That was the only therapies that were around when I was a child. IV fluids, penicillin prophylaxis, pain medication, and oxygen. But as I just mentioned, hydroxyurea study was done in the 1990s, and it proved beyond a shadow of a doubt that hydroxyurea can improve health outcomes. And I'm going to just say this for the large majority of sickle cell patients. I say that because there are individuals with sickle cell disease that I've been friends with that I trust deeply that said they didn't benefit from hydroxyurea, that they didn't get the outcomes. So because I trust them, because I trust what they say, I do believe that maybe not all sickle cell patients benefit from hydroxyurea. But I strongly believe that every sickle cell patient should try. And if it works for you, every sickle cell patient should stay on. But there are barriers to hydroxyurea utilization. And as I mentioned, you know, some of those barriers were patient barriers. We had patients that were saying, I don't want to do this because it's an experimental drug. I don't want to do this because you have to, you know, do all these blood tests. I don't want to do this for other reasons. There were also, and there continue to be in the United States anyway, provider barriers. Hydroxyurea was discovered and used as a chemotherapy drug. So because it was used as a chemotherapy drug, is there a chance that it could cause cancer or increase the risk of cancer? Perhaps. You know, I don't know. I can't say no, it doesn't. And in medicine, you never want to be definitive about things because things do different things in different people. But I've been taking it for 28 years. I've never gotten cancer. And the data shows out that it doesn't increase the risk of cancer. But you do have the doctor still saying, like a primary care provider would say, hey, that's still outside of my level of expertise. I'm going to refer you to a hematologist. Unfortunately, in the United States and probably in Canada as well, not everyone may have easy access to a hematologist. So we do have to find ways to get more providers that are willing to utilize and prescribe hydroxyurea, particularly in those rural areas, those areas where it may be difficult for patients to gain access to the doctors that are prescribing hydroxyurea. But we have to start looking as a population of sickle cell patients, how do we create those healthcare systems that allow us to have access to the doctors that treat use hydroxyurea, but also in the emergency rooms and those other areas, how do we get access to those educated providers? This that I'm just showing on the screen is that we did have the strong, very strong evidence that hydroxyurea was effective for sickle cell disease. So if you have sickle cell disease, you know someone that has sickle cell disease, I strongly encourage you to consider hydroxyurea. I'm not just saying this because I'm a sickle cell patient that has benefited from it. At NHLBI, at the National Heart, Lung, and Blood Institute of the National Institutes of Health, where Dr. Fauci works or used to work, we did the research, and we found that it does have strong evidence for treating sickle cell disease. But having hydroxyurea available to us, hey, and I'm now working on teams that work with gene therapy, the gene editing that's come out through Vertex CRISPR and through Bluebird Bio. So we now have another cure in the arsenal, another treatment in the arsenal. But having those treatments is not enough. We have to look at how do we allow individuals to get that better access as well. And in order to do that, we have to look at what's called the social determinants of health. The social determinants of health is that environment around us that influences my health. It's not just about having sickle cell disease, but it's also, hey, having access to healthy foods, having access to environments that allow me to exercise and work, having good, strong housing, having sanitation and water, having work opportunities and education opportunities. All those things have an impact on sickle cell disease as well. All those things have an impact on me staying healthy as well. So now, I was in the United States. I am currently in Canada. I live in Georgetown, Ontario. That's not too far away from Toronto, Mississauga, Brampton area. But I still have to look at how do I live beyond my sickle cell disease. Sickle cell disease is important, but it's not the only thing that I need to consider as I live my lifestyle. In the United States, before I left to come to Canada, I did work at the Health Resources and Services Administration. Our organization is part of the federal government, along with the NIH, along with the CDC, along with other government agencies. And we all came together to look at how do we improve sickle cell disease care in the United States. We're still working through several different models. And in the United States, part of the issue in the United States is that the United States doesn't have one healthcare system. It has 50 healthcare systems. Each state has its own healthcare system. And the same thing to a certain degree is in Canada. Canada doesn't have one healthcare system. I know we look at it and say, oh yeah, hey, Canada has universal healthcare. Well, Ontario has one healthcare system that's much different than Quebec, that's much different than British Columbia, and that's much different than Alberta. So in Canada, we have to look at it and say, well, actually, we have 10 healthcare systems. And if you're in Ontario, you're underneath the Ontario healthcare system. The reason I say that is as we look at strategies to improve sickle cell care, we have to look at how do we partner, how do we lobby, how do we do whatever we need to do to get the Ontario government to say this needs to be done. And then even taking it a step back, we also need to look at how do we partner with, how do we get on our side those hospital systems. I currently go to Dr. Quo. He's my doctor. He's at the University of Toronto. I know an excellent doctor, Dr. Madeline, that's down in Hamilton. There are other doctors in other areas that we need to figure out how do we build a network so that no matter where an individual with sickle cell disease lives, they can get access to good care. So I'm going to stop there. I know I'm probably running out of time, and I do want to have discussion, but I look forward to continuing to work with all of you on improving access to sickle cell care. Thank you.
Thank you, and I appreciate the way you navigated the internet well, so expertly, Dr. Ivy, and thank you so much for shouting out two members of the SCAGO family, Dr. Madeline Verhofstadt, as well as Dr. Kevin Quo. They definitely are longtime supporters and contributors, and I really appreciate the compelling story. But that does not take away from our next speaker, and I'm really waiting with a bated breath for Mary to share your presentation. There's two things. I can either share the deck for you, or if you feel more comfortable, I can let you share it on your end.
Yeah, I'll try to share it, and
Okay,
we'll see how the internet goes.
beautiful. Okay, take it away.
Okay, so first off, my name is Mary Odwally, and I just wanted to say thank you so much, Dr. Kuo and Dr. Ivy, for what has been a wonderful learning experience for me as well. Powerful testimony, so thank you so much. So I do have a slide, so if you can just bear with me for a minute while I start to share. Okay,
Perfect. We can
so
see it.
you guys can see it? Wonderful.
Yes.
Okay, so I just wanted to talk to you guys a little bit today about our hydroxyurea story, a journey, and from a parent's perspective. So basically, I wanted to talk to you about what are some of these modifying therapies. What is hydroxyurea? We've got a great overview from Dr. Ivy already. What are the considerations for us when deciding to start hydroxyurea? How do I prepare an oral solution from capsules? And what should I be asking my healthcare team? Tips and opinions, and of course, we'll be doing some general questions. Okay, so what are modifying therapies? So these are therapies that focus on correcting genetic defects caused by sickle cell disease. And so, oops, sorry, let me go back. So the cures. So there's gene therapy, which involves gene insertion and gene editing. So this is what Dr. Ivy was talking about in terms of CRISPR, which is looking at manipulation of the BCL11A gene, which allows an individual who has suppressed hemoglobin, fetal hemoglobin to start expressing fetal hemoglobin, and this lentin-globin BB305, which is a functional copy of the gene, is being inserted into the patient's own bone marrow stem cells. So we also have this idea of bone marrow transplants using sibling matching or unrelated donor matching. And so treatments are also available, which are hydroxyurea, which we have been talking about extensively today, voxylator, L-glutamine, blood transfusion. Thank you so much, Dr. Crow, for all of that information, and crisanolone. So I think for me, I didn't really hear very much about any of the other treatments. When I was discussing with our healthcare team, it was mostly focused around hydroxyurea and blood transfusions. Okay, so what is hydroxyurea? So we've kind of already had a wonderful overview. It's also known as hydroxyurea or hydroxycarbamide. It's abbreviated to be HU, and I'll be referring to it as HU quite extensively in this presentation. Basically, as mentioned before, it is a cancer medicine. And it is basically allowing you to have like a synthesis of the ribonucleotide reductase. So in terms of sickle cell disease, low concentrations are useful to help produce fetal hemoglobin, which is resistant to sickling. And this is done by a mechanism where patients then see a reduction in the frequency of the cell crises and improve blood flow and therefore improving health outcomes. Okay. So there's an chemical structure, if that interests you, down at the bottom, and actual image of the pill up at the top. Okay, so where did I find additional information? Well, you can go to sicklecellanemia.ca. SCAGO itself has done a wonderful symposium on hydroxyurea, and so the link is available there. I also went to the Mayo Clinic, Medline Plus, aboutdrugs.com, and the Sick Kids has the About Health, which has an interesting little video on hydroxyurea, which really just speaks to it as a very user-friendly sort of way as to how to get started. Okay, so some of the side effects. So we kind of did cover this. So white blood cell counts can be lowered in some patients, which makes them more susceptible to infection. At least it's thought to. You have reduced platelet counts or red blood cell counts. There has been reported gastrointestinal issues such as ulcers, sores, diarrhea, and nausea, liver and kidney issues. And I think the take home is that, you know, on paper, this drug is reported as carcinogenic and teratogenic, meaning that you really don't want it getting into unintended systems, whether those systems be people or environmental systems. So much respect to it as a medicine that needs to be handled with care, disposed of properly. And of course, if you're teratogenic, meaning that if you are pregnant and you have exposure to this drug, it can cause mutations in your unborn child. Okay, so what were the considerations for my family? So there was a lot of fear. Fear, which, can I give this cancer medicine to my child? Fear that there would be profound long-term effects, including the onset of cancer. Fear that it would affect my child's ability to procreate. Fear of the unknown in general. I didn't really understand how the medicine worked, and I was skeptical. So even when I read the literature, I think I didn't really understand it. And it wasn't until somebody explained it to me this way that I started to understand. It's like you have a factory, and this factory has it's making defective widgets every once in a while. It's making defective widgets, and these widgets are going around causing delays and causing stoppages. And so when you introduce something like hydroxyurea, not only is it's like adding an additive to that manufacturing process that reduces the number of defective widgets being made, but it also increases the amount of reliable widgets that are being made. And over and above that, the molecular shape of the fetal hemoglobin that's being produced is slightly bigger than a normal adult hemoglobin. And it actually almost works like a bouncer, kind of coming in and seeing through your blood vessels where there are blockages and knocking them out of the way. So it can, if it works for you, can have a very profound effect on you molecularly. So what was the reality? I didn't know anybody who was on this medicine. I didn't know about Dr. Ivy. And so I was kind of left on my own to kind of do my own research and come to my own conclusions. So I had to rely very heavily on our care team to provide some answers. And the reality is that SickKids has been actually prescribing hydroxyurea for about 30 years already. And what they shared with me is that there was no increase to the risk of cancer, that it was associated with increased life expectancy, increases in organ function generally, decreases in the episodic pain crisis, decreases in the need for blood transfusions and other medical interventions, and there was an overall increase in the overall quality of life. So, what was the outcome effect for my family? Well, we went from about 2 admissions per year, and these were from about 1 week to 2-week stays in the hospital. We went from about 6 or 7 ER visits. So my child would go to the ER for fever or at least once for uncontrolled pain. And this has gone down since we started hydroxyurea back in October. So we're still new at this, down to just 1. And it was, she had a flu. And so she had a fever based on the flu. And so we took her in just to get her evaluated. So we went from 4 major crises per year to 1 minor one since starting hydroxyurea. And the care team thought that the dose that she was currently on is quite minor. It's quite low. Essentially, it was introduced to her to test out her tolerability, and we can probably have even better outcomes in the future. So the prescription has been slightly increased for the last month and a half, and so far we have had no sickle cell complications so far. This is not an image of my daughter, but my daughter does have hair very similar to this. It is a beautiful, thick, tangly head of luscious hair, and she has not had any change to that since starting hydroxyurea. She's also gained a small amount of weight, which is good because she was underweight for her height, and she seems to also have had an increase in appetite. She's also seems to have a small increase, very modest, in the amount of energy that she has in general. And I would say at this particular point in terms of sickle cell complications, this is the most major one that we're dealing with right now, that she just seems to fatigue more easily. And because we've had less need for medical interventions, there's been an increased ability for me as a mom to be able to work. And so that's had a positive financial benefit to my family. Okay, so how do I prepare a solution? So this is a little video, hopefully you guys can see it, of how I, on a daily basis, prepare the hydroxyurea. So the issue is in Ontario, we only can get the 500 milligram capsules. And so for smaller individuals, such as my daughter or babies, this dose needs to be split up because it's weight-based. And so I need to take the capsule and essentially dissolve it, and I'll start the video and just walk us through it. So I'm in my kitchen, that's me. And I'm right on top of my stove. So that's my stove top that's there. And so I actually use it as a good way to make sure I've gotten all the pots and the stuff from dinner all cleared up. So, and I get the kids started on an activity. So I have a moment to actually do the preparation. So great thing about COVID is that it's made medical supplies such as masks and gloves more available. So I don those, put on mask and my gloves, take off the cap for the mixing tube, as you can see, and then I actually get the hydroxyurea. Okay. And that's what the pill looks like. So this next part is actually, I find, the trickiest part. It's with using gloves to open up the capsule such with the right pressure and tenderness so that all the contents then can fall into the mixing tube. So that's the little piece I think that was actually the largest learning curve as to how to handle the capsule with gloves on. And I usually cap the capsule back just so that if there's any aerosolized particles, it stays inside the capsule. And then I get to, my next step is to actually get it into solution. So that's water, just regular old tap water, which I will syringe exactly 10 mils. And get that into my mixing tube. And I always check the meniscus line to make sure that it's exactly 10 mils. It's important to be consistent and reliable. So as you can see, 10 mils. Okay, put the caps back on and then start the mixing process. So what I have found with these capsules is depending on the make of the manufacturer of the capsule, you get different mixing times. Some dissolve more readily, and you can kind of see a pellet forming at the bottom where it has fallen out of solution. So you're going to keep mixing until you get all of the medicine in suspension. So as you can see, there isn't anything that's falling out of solution. So this is ready for being aliquoted and ready to be given to the patient. Mixing, 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 mixing. Okay. And so take off the top of the mixing tube and pull my syringe. Okay, using 10 milliliter syringe. And basically going to pull in exactly the amount that's aliquoted for usage. And I would advocate getting a top onto it so that you can then actually dispense the medicine when it's convenient for you. So we do that nightly. So the next step would be, I just wanted to go over the last step, which is disposing. Oops, hold on. Let's get to the next slide. Okay, so this part here just goes over disposing of any leftover liquid that's in your mixing tube. And so I have a hazardous waste bottle. And so I just basically take the top off, empty the contents that are for discard until that bottle fills up. It's important not to put any of this medicine down into the wastewater system. It needs to be handled very carefully. And this bottle, when it's full, can go back to the pharmacy and they can dispose of it properly. So just important step to keep the medicine out of unintended systems. And then again, you can go and give the medicine to the patient. Okay. Okay, so some questions that you can have for your healthcare team if this is a consideration for you. How does hydroxyurea work? Have your healthcare team explain to you in such a way that you ultimately understand it. What are the risks and the benefits? What are the potential side effects? How will hydroxyurea therapy be monitored moving forward? Like, how often will the patient be followed? What kind of blood work would you expect to have done? Are there any pregnancy or fertility considerations? If this patient is on other medicines as well, what are some of the possible interactions with these other medicines? What about missed doses? What about purposefully skipped doses? And I mentioned that because I had learned that if a child is sick, you might want to think about just temporarily stopping hydroxyurea depending on some blood work being done. And what are some other therapy options? Just so you're making the best decision for you and that you have all of the information available to you, and have the conversation about, potential cures as well while you're there. Okay, so a couple of tips. So I found it helpful to document the incidence of illness before starting hydroxyurea, so that you have a good idea of how it's working once you've started it, or if it is working. So optimally, the goal would be to be on hydroxyurea before any major illnesses happened. And so when you are, as an adult, it's obviously never too late, but also as a child, so that you don't have those damages, the damaging effect of sickle cell disease operating for long. Hydroxyurea needs to be started when the patient is healthy, so that they can take some baseline measurements, for what the hemoglobin is, values are. And it's not something that you would want to start during an ER visit, but definitely start having the conversation so that when, for instance, the patient is in a more, stable state, you can take some of those measurements and continue to monitor from there. Listen to the recommendations of your healthcare team. Ask questions, follow instructions the best you can. Document any side effects, and discuss each concern with your healthcare team. Reorder your medicines on time, and ensure to ask for free supplies like the syringes, the mixing cups, etc. Discuss pill crushers and how to keep hydroxyurea out of unintended systems. Have a plan in place. Be organized as much as possible. I mean, for me, I'm a parent with 2 kids and life can be crazy sometimes, but this particular aspect of life, I try to keep very, very structured. And keep on top of baseline testing numbers, such as hemoglobin concentration, fetal hemoglobin concentration, before starting the therapy, what the optimal target concentrations are, and what the current delta is. And of course, find your tribe. Join the sickle cell support groups on WhatsApp, make personal connections, go to the symposiums, be involved with SCAGO. And also consider trying to find a compounding pharmacy that can help with doing the mixing, or become comfortable with doing the mixing yourself. Specifically, if you are thinking of becoming pregnant, or you are pregnant, then handling hydroxyurea may not be something that you would want to do, and so you might want to get help in that area. So some things that I have positive feelings about since my family members started hydroxyurea. It's relatively affordable here in Ontario because we have generic brands that are widely available. So you may have extra costs that are associated at the pharmacy with compounding and mixing. So you can avoid these extra costs if you're comfortable with doing the mixing yourself if it's needed. And so this is for children who are unable to swallow the capsules or need a concentration that is less than the minimum milligrams that are available in the capsule. So the great thing about it is you don't have to do the math. That's done by the doctors and the pharmacists for you. They basically give you the instructions. It's relatively easy to mix. You really don't need any special equipment, but pill crushers and agitators are available on Amazon or Temu or wherever you can order. And you can also go to your pharmacy supply store and buy the supplies that you need quite readily. Some things about the journey that I think could have been improved. I still have these questions in terms of being able to batch individual preparations. Is it necessary that when I put the capsule into solution, that it's really has to be, given to the patient? How long do I have ultimately before it expires? Right. And so understanding how long each preparation is stable for is something I still don't necessarily have right now. I know that when you are buying it from already pre-mixed from the pharmacy, they give an expiry date for that solution for about, I think, a month or 3 months. But when I'm making it at home, they say make it freshly every day. So I think, batching it would definitely make it easier as a parent. Having more pharmacies that have the ability to mix for low cost or free would also help. And so, in terms of safety and drug delivery accuracy concerns, doing the preparation in a negative pressure fume hood would also probably be best. I mean, I'm doing it on my stovetop, and the exhaust from my stovetop goes up into the attic space. But having appropriate cleaning protocols to help keep the medicine out of the unintended would be helpful. So I think these are things from looking at it like in terms of accuracy and environmental perspective can be probably improved. And I think the biggest thing would be to demystify the off-label usage for sickle cell disease entirely. It would be nice to see that, it's indicated for use and that there's a clear separation between sickle cell disease usage of hydroxyurea and its use as a chemotherapy medicine. Have clinicians and pharmacists be more clear about the brands, like the individual marks for hydroxyurea that may not dissolve so easily, and maybe avoid those for when you have a young patient who needs it to be mixed. And have the drug available in smaller doses would also be helpful, maybe 250 milligram dose or 200 milligram dose. So if you do have a child who can swallow pills, you can avoid the mixing step altogether. And then it just gives you more options for mixing as well. So what's most important about sickle cell disease in my perspective? The life expectancy, that chart that was shown was just amazing in terms of within a lifespan, the overall life expectancy now can be in the 50s, 60s, and 70s even. But it's still important to recognize emergency situations. And so when you need to seek emergency care and having conversations with your healthcare team is so important for that aspect, right? So overall things that keep you healthy are still important. Staying hydrated, eating a balanced diet, getting regular medical monitoring, and interventions that might have hydroxyurea, transfusions, and cell modifying therapies. Also having good exercise and health and recovery and mental health as well, and avoiding of extreme temperatures. And I think the take home is that the science and technology for this area is evolving quickly. And so it's always a good idea to reserve time each month to kind of access some of the newest news. And in summary, I have found that after starting hydroxyurea, the need for medical interventions have gone way down for my family. I've also noticed that the episodic pain is also less pronounced and much easier to control. and I'm being told that my child is on a low dose and that this can be addressed even further. And so there's hope. There's a bright outlook and there's hope. So what's important to also remember is that the dosage is sensitive to weight. So as a child grows, the dosage may need to be adjusted periodically. And also, if the child is sick or colds and flus, you want to have the conversation about whether or not it's advisable to discontinue hydroxyurea until the patient is feeling better. And overall, these innovative therapies have become available. I have a good framework for being able to fully consider these other therapies. And so, like I said, the outlook is pretty good for my loved one, and we can expect overall better health in general, which is the goal. So I think that's the end of my presentation. Thanks so much.
Mary, if folks can give me 2 moments. One, I just want to thank you, and I wish I had flowers to hand to you in person right now, just to recognize how lucky your little one is to have a mom like you. I honestly hope and pray that all little ones who are navigating sickle cell disease have a mom like you. Secondly, you masterfully presented, I think, like some of the interstitial tissue, the stuff that folks kind of lose sight of, the day-to-day, what that looks like, what that means. I know you have a background in biochemistry. Thank God you do, because just the dilations you're doing and all the different mixing and ensuring that the actual accuracy of the dosage. Just thank you. Thank you so much for sharing that story. Thank you so much for being here. You're fantastic. So without further ado, folks, this is the time now for you all to take advantage of the speakers we have. And thank you, Dr. Cole, for joining us. Really happy to have you here. This is now the question and answer period. So I see there are a few folks who have their hands raised, as well. Some questions in the chat. Etta, you had your head raised a little bit. I'm going to allow you to talk now, Etta. So please go ahead. You can pose your question. You're currently on mute. Once you can unmute yourself, you can pose your question to whichever the speakers you had a question for. Sorry, I muted you by accident, Etta. Please go ahead. Just unmute yourself. There we go.
Hello, can you hear me?
Yes, we can.
Okay, I just want to say thank you everyone for all the great information you're sharing today. I really appreciate it.
Oh, fantastic. Thank you, Etta. Let me just see. No problem. Are there any questions in the chat? No, I'm seeing a lot of thanks coming from folks commending you, Mary, on being a great mom, overcoming fear and doubts, all the thoughtful nature of your presentations. Marlene, I see you just started your journey. Thank you for sharing that as well. Q&A from Maria. I find one of the biggest burdens of care for starting hydroxyurea therapy is the blood testing that should be done regularly to optimize the therapy. Has that been a big issue for you? I think all three of you could potentially respond to that question if you'd like. So maybe I'll start with Dr. Ivy.
Yes, and that could be one of the barriers that exist. It can particularly be a challenge for individuals, as I mentioned earlier, that might live a distance away from the hematologist. I'm not as familiar with Canadian systems, but one thing that you can try is having your hematologist coordinate with a local provider to take the blood and do the blood work. So the blood work doesn't have to be done at the hematologist, but you are correct that you will have to have frequent medications as they titrate or increase the dose to your maximum tolerated dose. So that can be a challenge, but I encourage you to talk to your doctor and then see if your doctor could potentially create other ways that you can get the blood test done locally if you're in those rural areas.
Dr. Cole, anything you wanted to add?
So at least at my center at the UHN, I've created a system where the blood work is almost like automatic in the sense that, yes, Dr. Ivy is correct that during the titration phase, when we increase the dose, we need to look at the blood work monthly. And the way it works is that patients will be going to their local lab, so their neighborhood labs. That lab will then be sent to me, and I will be looking at them, and then I will then be saying back to my secretary and ask my secretary to call whether to, continue on the same dose or whether to hold it or not. But once I tell my patients that it takes around 6 to 9 months to get to maximum tolerated dose, but once my patients are on maximum tolerated dose, all they have to do is just maybe do blood work once every 3 months. And now I'm exploring the possibility of even doing less than every 3 months.
Awesome. Awesome. So there's potential there. Thanks, Dr. Kuo. Mary, anything you want to add about having to navigate this with your little one, or?
Sure. It was exactly as Dr. Ko indicated. We got the requisitions for the blood work at the clinic visit. And so we were sent to our local neighborhood lab to get the blood work done. And we were told when to do it. So we were told to do it within 2 months of that clinic visit, assuming we were starting hydroxyurea that day. We didn't start that day. We started a week later while I was just getting my own system ready. And so basically 2 months and a week, I went and had her blood work done, and it was sent back into the sick kids clinic. And they didn't call us with any adjustments. They had us stay the course, and we didn't have any adjustments until we came back for clinic visit, which was 6 months later. And then we got a new prescription, and we're almost at the point where I have the blood work where I have to go back and get that done again. So for us, it's been a lot less intense, but I have heard that there has been more frequent monitoring for other patients.
Thank you for that, Mary. So Etta, I see you have your hand raised. Please go ahead and take yourself off mute and pose your question to one of our speakers. You're still on mute, by the way, Etta. Okay, maybe while we wait for Etta to enable her microphone, if there are any other questions, folks, please feel free to enter them in the chat or the Q&A feature. Definitely, you want to take advantage of the speakers we have online right now. So any questions or burning thoughts or inquiries you've had, please feel free to submit them. I think I had one question as well, Dr. Ivy. I really appreciate the mention earlier during your presentation about not being definitive, in terms of trying to, one, build optimism, but at the same time being sober. How do you go about navigating that from a public health acumen about presenting these particular therapies as an option for folks, but not, giving them a healthy level of optimism?
Yes, so that's a great question, and as an individual that has lived, long enough to see a lot of the changes, as I said, I remember back when, they were doing bone marrow transplants for the first time in children, like in Washington State and at other centers. That proved to be huge in sickle cell disease, but at the time it was very limited because you had to find a matching sibling donor, and there were other restrictions. I also remember when it was tried in adults, it didn't work out as well in adults, but we've moved beyond that point now. And bone marrow transplant for matching, when you find matching sibling donors, works well in adults now. There is a lot for us to learn in sickle cell disease, but there are certain things that we kind of know right now. I can say, hey, yes, there's been randomized controlled trials, and this is proven, and this is fact. But you still have to be careful because situations can, be different. As I said, I was very fortunate to benefit greatly from hydroxyurea. I do have friends that they didn't find the same benefit from hydroxyurea. I believe there was one friend that died about a couple years back, Carlton Hayward. He did come to speak, I think, to SCAGO, back in I think it was like 1917 or 1918. He couldn't find benefit from hydroxyurea like I did, unfortunately. But, now, as it was said by Mary, it's not just hydroxyurea anymore. We have other therapies out there as well. And there's so many more therapies in the pipeline. There is a lot to be excited about right now in sickle cell disease. As I mentioned earlier, Bluebird Bio and CRISPR Vertex now have the gene therapies. The gold standard is still, if you have a sibling donor, to use that sibling donor match for bone marrow transplant. But we have therapies that are in the pipeline. Hydroxyurea is very effective, but we have other pyruvate kinase activators that are in the pipeline. We have other therapies that are in the pipeline to really improve sickle cell disease. But I try not to be definitive, and we always have to look, how do we improve where we are? Me personally, I recognize that, hey, renal failure is a significant complication in sickle cell disease. So I want to try to make sure I start addressing those things that could happen. I will admit I don't always eat the best diet. As Mary mentioned, I don't get the exercise I should, but it's important to stay optimistic and positive.
Beautiful. Dr. Kuo, I was really compelled by the statistic you mentioned in and around transfusion medicine and numbers needed to treat. So on that same notion about, therapies in the pipeline and transfusion showing the best promise, could you expand on that a little bit? Because I'm still kind of trying to make sense of it, in that when you hit that 6.7 number, we see a nice benefit to it. But I'm still trying to understand, how do the 6 people make it a more impactful kind of, therapy?
So the idea here is more of a public health figure rather than an individual figure when we talk
Got
about
it.
number needed to treat. The idea here is that some drugs may show, or therapies may show benefit, but then the benefit is so minimal that it's not even worth deploying, because you're going to waste millions and millions of dollars and no one is going to get benefit from it. Whereas there's some therapy that are just so compelling that there's no reason why you should not be putting money into it and putting it in for people to use. And if we take the 6.7 into perspective, what that means is that with any therapy, we're using it to lower the chance of having something bad happening. Okay,
Right.
it's like having safe drinking water can reduce the risk of cholera. It's not that the risk of cholera is completely taken away.
Right.
Certainly, if your water is clean, your chance of getting cholera is going to be very, very, very little, right? It's
Right.
going to be dropped quite a bit. So the bigger the drop in the risk, the more benefit that people are going to gain from it. So that's what that number points to, is that there's always a risk of people with sickle cell getting stroke. But then if we were to use this therapy, then we can, for every 6 people we treat, we can successfully prevent at least 1 stroke.
Beautiful. And just one more corollary question. Does that suggest that sickle cell patients that are maybe not simultaneously, but are using hydroxyurea therapy alongside transfusion, there's a significant reduction in risk of second stroke?
Yes, that's right. Yeah, because the second trial showed that in people, okay, and this is where we're going to be careful, right? Because this is in people who never had a stroke but at risk for stroke. Once they were on transfusions for a little while, when I say a little while, I mean 3 to 5 years, you can successfully switch them over to hydroxyurea and feel safe that the hydroxyurea will be protecting them from the stroke.
Beautiful. Beautiful. Okay, folks. So I'm hoping you all captured and were listening intently on that, because that is essentially what the point I want to drive home. And Marie is definitely thinking that as well. So, Mary, back to you. In terms of your preparation of, when you're delivering the hydroxyurea to your little one, how much training were you provided to kind of go through that process you helped share on your slides?
Honestly, little to no. I was given a little paragraph that had the instructions, and I was told I did have an opportunity to talk to the pharmacist, but it was busy at the time. And so I felt I was in one of the best positions to be able to figure it out. And so I went ahead and did that. I think honestly, the idea would be that you would sit with your healthcare team, come back to the pharmacy when they're not as busy, and make sure that you are comfortable. I think ultimately, if you were to try it at home, make a little video and send it to your healthcare team. Go back to your pharmacy. I mean, it is a cancer drug, so it's not like you can do it in the pharmacy itself, but you can use video. And so have them watch you doing it and help correct you so that you can feel confident moving forward.
Beautiful. Okay, folks, I know I don't want to dominate the conversation. I do have more questions. So if you do have any questions, please, once again, take advantage. We're drawing close to the end of time. I just want to get back to you, Dr. Ivy, as well. You mentioned in your trajectory from the early 20th century, 1910, and the advances we've seen both from a policy standpoint and, currently where we are today. What changes would you like to see happen in the near future?
So that's an excellent question. One, we have to look at, of course, the healthcare system, how to make sure that that's meeting the needs of individuals with sickle cell disease. So I would like to see every child have access to a knowledgeable provider. That's first and foremost. I wish we could clone Dr. Ko and have him everywhere in Canada. From Strathroy, which I'm going to go to in just a few minutes, which is a really rural area.
Yes.
To Toronto, where he's practicing and doing his work. But that's not the case. We don't have hematologists everywhere. And as I said, I'm not as familiar with Canada as I am with the US. But there are rural areas that may have sickle cell patients that don't have access to Dr. Ko, or it's very difficult to get to Dr. Ko. So how do we take Dr. Ko's knowledge and disseminate it down to Strathroy, to those other areas? So we have to do that. And then also with Dr. Ko treating emergency medicine. I've had a few experiences. I haven't been admitted for sickle cell pain yet, but I have gone to the emergency room. It's a little different here. I mean, it's, everybody waits a long time. But we
Let's
do
not
have
get
to
started. That's another topic for another day. Yes.
Yeah. But we do have to figure out, okay, those individuals that are in crisis, how do we get them cared in a timely manner that addresses their crises? Looking at, though, the system that we have in place and making sure that that's better. There are these curative therapies that are around the corner. I know right now, as I said, I work with the groups in the US that are trying to implement that. So there we have the Center for Medicare and Medicaid Services. They're looking at payment models because the therapy is extremely expensive, as you may know. I think Bluebird Bio is $3 million. Vertex, CRISPR is $2 million. But they are in the US looking at strategies to pay for that. And so I hope that they do the same in Canada. I think they're doing that in Europe. I actually, maybe working with them as well on some of that. But we have to look at how do we improve that strategy. But going back to, and I hate to dominate the conversation, but going back to what you said earlier, what I would love to see is every sickle cell patient have hope, that they don't have to suffer with sickle cell disease. There are effective therapies out there. If hydroxyurea doesn't work for you, we have other things now. It's not like when I was younger and all we had, as I mentioned, was IV fluids, pain medicine, and oxygen. We have a lot more in our toolkit now. So I would love to see us create those systems that allow sickle cell patients to get that access to care.
Fantastic. Dr. Ko, I see you have your hand raised. I also want to ask and pose a final question to you, but I'll let you respond first, and then maybe I can pose a question.
It's just that what Dr. Ivy just said between you and him, the conversation, Delaney, just inspired me. I think you should run a session on how to effectively advocate for timely treatment in the emergency department.
I'm going to definitely take that down as a suggestion,
I think that would be a good seminar to run.
Perfect.
And it should be it shouldn't be like
didactic.
Didactic. It should be more sort of interactive. I think we could get ideas from everybody.
I would like that. I like that a lot, actually. I want to do more of those sessions in the future, to your point.
And I would just encourage you, as we have that, if you know of any ER docs,
Mhm.
invite them
Jennifer
to
Bryan.
participate as well.
Yes,
Because they
exactly.
have to be part of the discussion. I can talk to them blue in the face, but then when I go to Georgetown emergency room, they're gonna, I have to negotiate with those doctors who have patients with priorities as well. So we have to
Exactly.
think about the system we live in.
Beautifully, beautifully said. Folks, I'm just going to post a poll for you to also send and submit any feedback about other sessions you'd like to see see SCAGO delivered to you. And Dr. Cole, last question. You mentioned the management of hemolysis and that, transfusion, it depends on the severity of it and the rate of it, but that transfusion, it has a I don't want to say an insignificant risk, but a relatively small risk. But then you mentioned there's a number of events that have happened in terms of it being fatal at your hospital. So back to your whole general theme of risk and benefits, could you give folks a bit more, hopefully, comfort in being able to arrive at a decision if transfusions where they want to go?
I think, first of all, we have to see what the indication is, meaning that what are the complications you're suffering from with the sickle cell disease? Because if it's a major complication, then no doubt about it, transfusion is probably the right way to go. However, if it's an indication where we either know that transfusion can't fix or that we don't have any evidence to show that transfusion can help, then that's something where you really have to think, is it worth it for me to venture into using transfusion, or could there be better ways of treating this?
Mhm.
For example, like using hydroxyurea or joining one of the clinical trials, or even asking about gene therapy, because gene therapy is coming down very
Nice.
sooner than we think, actually,
Nice.
thankfully,
Thankfully.
in Canada. So hopefully, in the next couple of years, we'll beginning to see gene therapy being brought to sort of bigger availability. At our center right now, we're actually running a sickle cell trial in gene therapy as well. SickKids ran theirs. We're running ours. Right now, enrollment is closed, but hopefully we can open up again very, very soon.
Beautiful. So folks, once again, there's a poll that's live. Please do submit your feedback via the poll so we can capture any suggestions or thoughts you have about today's session and future topics or titles of our future sessions. I just once again want to thank our speakers, Mary Odwale, Dr. Donnell Ivy, Dr. Kevin Kuo. Your contribution has been invaluable, and we wouldn't be able to deliver this kind of information without the likes and support from you folks. So I thank you so much for taking the time out of your busy Saturdays to be here. And once again, folks, we'll be having our Sickle Cell Disease Summit this coming August 23rd and 24th. We're going to be hosting another annual Hope Gala on June 15th. And for those of you who are unable to attend today's session or are participating by way of the recording on our website, thank you for listening all the way through to the end. Please be sure to circulate this and share the recording with your colleagues if you think they could also benefit from this information. And with that, I just want to thank you all for being such, steadfast contributing members of the SCAGO community. We really appreciate you, and we look forward to seeing you in the future. So with that, I hope you all have a lovely Saturday. Thank you once again, and it's been a pleasure.
Thank you.
Take care, folks. Thank you. Bye-bye.